Okay, so I'm Aadc Khalid, pediatric neurology consultant in King Faisal Specialist Hospital in Riyadh, Saudi Arabia. For disclosure, all three faculty members of this webinar have speaker agreement in place with BTC Therapeutics. And the meeting objectives for today to provide an overview of the common causes of misdiagnosis of AADC deficiency in clinical practice, focusing on the cerebral palsy mimics, and also to highlight the challenges associated with differential diagnosis, and to share the best practice to help avoid misdiagnosis through case studies, and also to emphasize the importance of screening to aid early diagnosis in this rare disease. So the meeting agenda. So after the introduction, we will have Dr. Asma Tawari will present differential diagnosis and mimics of cerebral palsy. Then Dr. Mohammed Al-Muqbil, closer look at CB mimics, time to suspect ADC. Then we will have our panel discussion if there's any question or answer. Then after that, we will have summary and the takeaways and close. So the faculty for today, I'm Aadc Khalid again, and we will have Dr. Asma Tawari, consultant pediatric neurologist and head of pediatric neurology unit, pediatric department at Al-Sabah Hospital, and also Dr. Mohammed Al-Muqbil, consultant pediatric neurologist and medical genetics and biochemical genetics department of pediatric at King Abdullah Specialized Children's Hospital and King Abdulaziz Medical City in Riyadh, Saudi Arabia. So hopefully this webinar will be interactive as the first one. So during the meeting, we will employ interactive elements provided by the online format. Through online interactivity, you will be able to interact with the faculty throughout the sessions and answer questions within faculty presentation and give your perspective on topics on the topics discussed. And when prompted by the faculty, choose one of the options to answer the interactive question. All result will be generated and will be shared on the screen. And please, you can submit your question to the faculty using the question and answer function. Just want also to mention that this webinar is 3 CME hour accredited, and the certificate will be sent to registered people hopefully by 10 to 14 days. So I will give an overview to the AADC before that Dr. Asma Tawari and Dr. Muqbil give their presentation. So neurotransmitter disorder comprise a rapidly expanding phenotypically and genetically heterogeneous growth. Most of these disorders starting in infancy through to the childhood and have various presentations. They may be overlooked if the phenotype lead to misdiagnosis involving various combination of developmental disorder. Okay. So ADC deficiency is an inborn error of neurotransmitter biosynthesis resulting from pathogenic variants in the DOPA decarboxylase gene, DDC, encoding for the AADC enzyme. Lack of the AADC enzyme will lead to a severe combined deficiency of dopamine, serotonin, and other also catecholamine neurotransmitters. So the absence of this neurotransmitter will lead to inhibited neuronal signaling in the CNS, which is required for motor development behavior and also autonomic function. Without dopamine, patients are often unable to gain motor function or achieve motor development milestone. So this is the prevalence of the ADC deficiency worldwide. You can see in Taiwan is 1 in every 32 live birth, and in Europe 1 to 118,000, and in USA 1 to 90,000 live birth, and in Japan also 1 in 182,000. So ADC first described in 1990s, and so far 130 patients reported worldwide, and more prevalent in Asian populations. So this is the prevalence of ADC deficiency compared with other genetic disease. As you see, it's 1 to 32,000 to 1 in 182,000 live birth. So compared with the spinal muscular atrophy, it's quite similar or a little bit higher. So loss of ADC enzyme activity will lead to prevent converting L-DOPA to dopamine and eventually to epinephrine or norepinephrine. This will result movement disorder or movement symptoms, including hypotonia, dystonia, ocular crisis, hypokinesia, bradykinesia, delay motor development, and also may cause autonomic function, which include the ptosis, nasal congestion, hyperhidrosis, temperature instability, and excessive drooling and diarrhea constipation. And also the ADC enzyme is important also to convert the 5-HTP to serotonin. And this may lead to behavioral issues, including irritability, excessive crying, and delayed cognitive and speech development. So patients with ADC deficiency are often underreported and underdiagnosed, and mean age of onset for patients with ADC deficiency is 2.7 months. And despite this young age of symptoms onset, the mean age of diagnosis is 3.5 years. And based on the calculation of presumed prevalence in European Union and United States and Japan, over 90% of cases of ADC deficiency are underdiagnosed. Okay, now I'm glad to introduce Dr. Asma Tawari, consultant pediatric neurologist and head of pediatric neurology unit in pediatric department at Al-Sabah Hospital, and she will give the differential diagnosis and mimics of cerebral palsy. Dr. Asma?
Yes.
Please go ahead.
I would just, Assalamu alaikum wa rahmatullah. I would just share my screen now. Yes. Assalamu alaikum wa rahmatullah. I would like to start with thanking the BTC for this interesting webinar, and also to thank the audience for their attendance. Actually, this is a very interesting talk, and really we have to again redig in this old disorders that we are used to deal with and manage on daily basis. And not only this, we are also in all aspects this disorder, which is CB, linking all the specialties together. So that's why we have to increase the awareness of our knowledge about cerebral palsy, what are the mimickers that might have other diagnoses and might need also important intervention, important reaching the diagnosis to this disorder. So let us get started. So as we are talking about cerebral palsy, that no one had not met a baby or a child with cerebral palsy, starting from neonatal period till adolescence. We are all having this, a spectrum of ages that the cerebral palsy passed through, and we all know the common disorders, the common etiology. But do we know the history? Yes, we know the history. So this term has been first used more than 170 years by Dr. William J. Little, who correlated a difficult labor and neonatal hypoxia with limb spasticity and musculoskeletal deformities. So it is known for us when we start learning about cerebral palsy that it is a non-progressive disorder. Yes, this is the group of permanent disorders of the development of movement and posture that cause limitation of activity and affect in the developing fetal or infant brain. Well, that's we all know. This information are well known to us. So the interference in brain development in utero related to either maternal infection like rubella or CMV or neonatal asphyxia. Okay. There are often synonymous with long-term neurological sequelae of a perinatal or infantile brain injury. All these information are well known to us, but just to refresh our knowledge about it. But we will get more interesting data when we go through these slides. Okay. As for etiology, as I said, we all know that the background of cerebral palsy is known to all of us from neonatal period till the adolescent period, that it might be during pregnancy or of prematurity, prenatal risk factors around it. And there are now accumulating evidence that shows the genetic etiology in 10 to 30% of cases, including both de novo and inherited genetic variants, means that we are now facing child with having features of cerebral palsy. He has global developmental delay or hypotonia, but there is no risk factors had happened to him during pregnancy or he is not premature. So there are quite high number of cases that are labeled as cerebral palsy but are not fitting the diagnosis of really cerebral palsy as a etiological background. So these are under the genetic or inborn error of metabolism category. So as Dr. Musa'ad has mentioned that the disorder that had been has prevalence, high prevalence, was underdiagnosed. Also, the cerebral palsy, we know it's have high prevalence, 1.5 to 2.5 per thousand live births, with it increasing in premature infants compared with infants born at term. Okay. So this slide shows the prevalence of cerebral palsy in Saudi Arabia area. Actually, there are several papers published from 1993 till 2011 by different authors from Saudi Arabia, which are all interesting in their conclusion, study and their article. And the important part of this papers, the prevalence of CP per thousand. As you can see here, from the 1993, it is 5.3 per thousand live birth, and 2.3 and 1.3 in 2009. So it depends on the sample size. We can see the prevalence is not a small number. So it's almost to the higher range of the prevalence in what it is known from 1.5 to 2.5 per thousand live births. And this is also emphasized that the category or the diagnosis or the prevalence of cerebral palsy is quite high prevalence or in the Saudi Arabia area, and I think this reflects the region as well. Okay, now we move to the cerebral palsy. As we all know, let us refresh our knowledge about it. It is a descriptive clinical diagnosis, as you all know. Not only this, independent of the etiology, it has a heterogeneous picture in all aspects: the distribution and severity of motor disorder, and the type of motor disorder, like it is either spastic, dyskinetic, or ataxic, and also it is heterogeneous in associated comorbidities, and the neuroimaging also, and the etiological background. It is also heterogeneous because it has different etiological causes. So as you can see, we are dealing with a quite broad spectrum of disease that has a real heterogeneity in all its aspects. That's why the importance of looking at this old term or the diagnosis of cerebral palsy is not now anymore to think about like in old ages that it is okay, hypoxic ischemic insult, or it's due to prematurity. No, we have to revive our thoughts about cerebral palsy now and change the attitude and change the approach as well. Okay, now we go to the classification of cerebral palsy. Cerebral palsy, we all know, and maybe in my practice, I should tell you that in cerebral palsy is headache to everyone because it has a wide spectrum and heterogeneity in its clinical feature and presentation. But this is also important to know, to dig for the underlying etiological background. So the cerebral palsy is classified into, if it insults the pyramidal tract, it will cause a spastic cerebral palsy, and it will cause, if it insults an extrapyramidal tract or extrapyramidal tract or the basal ganglia, it will result in athetoid and dyskinetic or ataxic cerebral palsy. Now, if we look again at this slide, that we have different clinical presentation features starting from hemiplegia, diplegia, quadriplegia related to pyramidal tract insult, which result in spastic cerebral palsy, or athetoid, dystonic, or ataxic cerebral palsy related to extrapyramidal insults of the brain. So here, as you can see, a wide spectrum of affection. So should we take this easy in our practice? I should say no. We have to know exactly why this happened. Okay. Now we come to this slide, which is also to me, it is a very, very important slide. The early signs of cerebral palsy may include, first, children with cerebral palsy will most probably have multiple disabilities, as we all know. And 80% would have one disability and 40% will have three or more. Over ages or over the periods of life, starting neonatal, infancy, adolescent age group, or toddlers, and then adolescent, they will have difficulties in their presentation or in their clinical features. Means that there will be an increased or decreased muscle tone, which result in arching of the back or poor head control, or inability to sit up by the age of 8 months or 9 months, and then seizure will appear, and which be denoting of epilepsy, and there will be uncontrolled body movement or unbalanced coordination problems, and again this coordination will reflect on feeding, eating, swallowing impairment. When he grow up more, there will be learning difficulties, behavioral problems, visual hearing problems, and sleeping disturbances and disorders. So these are really important early signs of cerebral palsy starting from infancy till toddler age group. Okay, now we come to how to approach a case with cerebral palsy. We all know basically medicine had based on medical history, physical examination, and additional tests for the differential diagnosis. The medical history is, we all know how to approach and how to get the report from parents and about motor milestones, attainments, and all these aspects of important behavioral issues starting from neonatal period till toddler age group and elder and older. Then we come to the physical examination, which is we have to know about milestone achievement, the posture by observation and by examination to check of uh, deep tendon reflexes, muscle tone, if it is hypo or hyper. And again, we have to proceed from physical examination to the diagnosis or to the additional test by neuroimaging, doing MRI or CT scan, and EEG also, of course, important. The other metabolic laboratory tests, which are important also to do plasma amino acid, urine organic acids, and blood acetyl carnitine profile. So why we emphasize on this? Because it will improve our counseling, our prognosis, and often to specify the therapy for the patient. Okay. Talking about all these issues, now if we search for the etiology of cerebral palsy, as I said earlier, we all know cerebral palsy, I mean by heart, we know it's a complication of birth asphyxia, hypoxic ischemic insult, or complication of prematurity, which is the leading cause, and maybe congenital brain malformation, which account for 10% of the cases, and others like infection, trauma, metabolic, and or combination of all these risk factors that cause cerebral palsy. But again, we have a group which is not small group of unknown, undiagnosed cases which account for 10 to 30%. They have normal neuroimaging, remember, and absence of perinatal events. They are likely to be genetic. So these two important data, keep it in your mind. If you have normal neuroimaging, absence of perinatal event, you have to think of genetic background, which account, this group account for 10 to 30%. So we have to keep in mind, if we don't find any etiological background with normal neuroimaging, a child who is affected neurologically with absence of perinatal event, we have to think about genetic background. Okay, so now we come to classify this group, which is 10 to 30% of cerebral palsy cases that we all know as CB mimics. However, the International Cerebral Palsy Genomic Consortium discourages the use of this term CB mimics and encourage a subclassification based on etiology. For this purpose, they call it a clinical syndrome consistent with cerebral palsy in the absence of documented risk factors or neuroimaging finding consistent with a history of brain injury or a congenital cerebral malformation. Now, from this, we understand now that CB is really a quite big entity or disorder that underline. We have to dig in to know the etiology if we couldn't find. Because remember, 10 to 30% are unknown and might be genetically determined. Okay, we will move now to have more idea about the clinical feature that should prompt evaluation for genetic and metabolic condition in a patient presenting with symptoms of cerebral palsy. These are important. Maybe you will remember them, maybe you will not, but at least to keep some of them in your mind. What are they? First, the most important thing, if there is no history of any perinatal risk factors for brain injury, and there is positive family history with similar neurological symptoms. Honestly, we have cases present to us in our practice in hospital, two girls with labeled as cerebral palsy, and they have really spasticity, and they have I mean no event in their perinatal risk factors, and we discover they are not cerebral palsy, they are diagnosed and another genetic disorder, which is not, I mean, AADC, but really this is our practice would be occurring. Again, the onset of motor symptoms or after an initial period of normal development. So this is also important to have a normal developmentally infant, then he will regress